You may be familiar with nitrous oxide. It's a staple for many dental procedures because it's so safe. So why is it not used as an anesthetic for extended surgeries in most veterinary practices? In this lecture, we'll be discussing this and the characteristics of other inhalant anesthetics. These are compounds that produce unconsciousness when inhaled as a gas or a vapor. You'll find out that some inhalant anesthetics, like nitrous oxide, are only in the form of a gas, so they're transported basically in tanks. But most are vapors available in liquid form, but they produce their effect when they evaporate. Inhalant anesthetics are administered into and eliminated from the respiratory tract. They have to be administered continuously to maintain an anesthetic plane. The most commonly used are isoflurane and sevoflurane. Desflurane is recently available, but it's quite expensive. Isoflurane, sevoflurane, and desflurane, the more modern compounds, are all halogenated ethers. Less commonly used is nitrous oxide, but it has a useful niche in our repertoire of drugs. Finally, there are drugs that we'll cover that are just of historical interest. Their characteristics make them useful points of comparison. The oldest inhalant anesthetic, chloroform, has a poor therapeutic ratio because it produces severe cardiovascular depression. The lethal dose hovers dangerously close to the anesthetic dose. Diethyl ether, the compound that replaced chloroform, is still used in some developing countries because it's cheap and has a better therapeutic index than chloroform, but it's dangerous because it's flammable. We'll find out why isoflurane and sevoflurane are popular, and also why methoxyflurane and halothane, more recently used compounds, are not any longer. The reason that inhalant anesthetics are used so widely is because they offer several advantages over other types of anesthesia. First of all, the depth of anesthesia is easy to control, and there's a rapid emergence from the anesthetic episode when delivery is terminated. They don't lend themselves to abuse because they're more complicated to deliver. And finally, they produce a good skeletal muscle relaxation compared to many other drugs. They do have a few disadvantages that you should be aware of. They require expensive equipment to deliver the compounds correctly. The head and the neck are less accessible, so they're not the first anesthetic of choice for procedures on these areas. The excitatory phase lasts longer during the induction of anesthesia, so they often need to be coupled with other drugs for induction. So what do you need for an ideal or a balanced anesthesia? First of all, an anesthetic should produce rapid and complete unconsciousness. In the case of inhalant anesthetics, the transient excitatory phase during induction can be addressed by injecting an induction agent first, and then, when the animal's down, follow with the inhalant compound. An ideal anesthetic would also provide some analgesia. This is important even when the animal is unconscious because the tissue damage caused by surgical procedures can sensitize nerves. Then, when the animal recovers, the animal experiences more intense pain, more diffuse pain, and the pain persists for a longer time. As a result, more analgesic drug is needed during recovery than in patients that received analgesics prior to these sensitizing manipulations. Because inhalant anesthetics are not analgesic except for nitrous oxide, they're often accompanied by an analgesic drug when used for most procedures. The degree of skeletal muscle relaxation produced by most inhalant anesthetics is good, especially compared to many other anesthetic compounds, but it may still be inadequate for certain manipulations, either for visualization of an area intra-abdominally or for the repair of muscles and tendons. Finally, an ideal anesthetic would not interfere with autonomic reflexes, but inhalant anesthetics usually suppress the sympathetic nervous system, so the resulting decrease in blood pressure may need to be addressed pharmacologically and with fluid therapy. To describe inhalant anesthetics, we need to define some terms used for gases. First of all, the vapor pressure of a liquid is simply its tendency to evaporate. The saturated vapor pressure is the maximum or ceiling vapor pressure at a particular temperature. The partial pressure of a gas in a mixture is the pressure that it would exert if it were the only gas in a particular space. When an inhalant anesthetic is delivered, it causes the partial pressure of the gas to build up at its site of entry, that is, in the alveolus, then in the blood, and then in the brain and other tissues, following its concentration gradient. When the anesthetic is no longer delivered, when the delivery is terminated, this causes a new and reverse concentration gradient. So the gas goes back out to the exhaled air in the reverse order. So how do you calculate the dose of an anesthetic? It's expressed in terms of the partial pressure or volume percent. We know that the partial pressure is just the pressure exerted by that one gas. The total pressure in an anesthetic mixture would be the sum of not only that one anesthetic, but also the partial pressure of the air, including oxygen, nitrogen, and so forth. So that portion of the total pressure that is just the anesthetic is a fraction of the inspired gas mixture, or if multiplied by 100, a percent of the total mixture. We call this the volume percent. You can increase the volume percent by increasing the rate of delivery of the gas relative to the air or oxygen mixture. But remember that you need to allow enough room for oxygen. When the gas reaches the blood and tissues, the partial pressure is still in a gas form, in the form of bubbles. Think of it as a bottle of Pepsi. The gas in the can is in two forms. There's gas that exists between the water molecules. That portion bubbles up to the top when you open the bottle. This happens because the pressure is decreased suddenly and the gas expands enough so that you can see it. It's lighter than liquid, so it rises to the top and escapes. In order to describe the partial pressure of a compound relative to its ability to induce anesthesia, we express the concentration of the gas as the minimum alveolar concentration, or MAC value. The MAC value is expressed in terms of volume percent. So the MAC value is somewhat like an ED50 in that it's the volume percent that will produce a surgical anesthesia in 50% of the animals. In addition to the gas, there's also a small fraction that's actually in solution, attracted electrostatically to the water molecules in their slightly negatively charged hydroxyl and positively charged hydrogen states. The partial pressure is not the small amount of gas that ends up being dissolved in the blood and other fluids. This dissolved gas has consequences that we'll discuss later. Let's think about what that means in terms of the clinical use of MAC values. Because it expresses how much gas is needed to induce anesthesia, the anesthetics with the lowest MAC values are the most potent. That is, it takes less of them to be anesthetic. If you administer a gas at its MAC value, it would probably produce a light anesthesia. Surgical anesthesia is usually about 1.5 times the MAC value, and deep anesthesia is about 2 times the MAC value. The MAC value depends on the species, the age of the animal, any pre-existing conditions, other CNS drugs that have been administered, and the ambient temperature, because that influences their vapor pressure, that is, their evaporation. Here are some of the things, mostly drugs, that can decrease the MAC value for an inhalant anesthetic. Remember that a decrease would mean that less anesthetic is necessary to produce the same degree of depression. These are things that you'll review in more depth in anesthesiology. Here are some examples of MAC values expressed in volume percent for a dog, a cat, and a horse. The first thing to notice is that the values in these different species are not significantly different from each other. One question that arises from this data is, how can you have a gas with a MAC value of greater than 100% like nitrous oxide? The answer to this is that the values for nitrous oxide are theoretical. It's such a weak depressant compound that it's simply calculated by extrapolation, predicting how much gas it would take to induce an anesthetic episode. So it's not truly an anesthetic agent at sea level. However, if the pressure were increased, like surgery under the ocean or in a hyperbaric chamber, it would eventually become depressant at a lower volume percent. It's similar to the situation with nitrogen, which is not an anesthetic at sea level, but is a weak anesthetic gas under pressure. It only can cause nitrogen narcosis when people dive to depths at greater than 100 feet. Next, you'll notice that halothane and methoxyfluorine have very low values, mostly less than 1. In contrast, isoflurane, sevoflurane, and desflurane are somewhat higher. That means that halothane and methoxyfluorine are very potent in their ability to induce anesthesia, while isoflurane and sevoflurane and desflurane are all less potent. Yet, halothane and methoxyfluorine are old, rarely used inhalant compounds, whereas isoflurane, sevoflurane, and desflurane are new and widely used. Wouldn't you want to use the most potent drugs available? Apparently, potency isn't the most important characteristic in their clinical use. What is it about these compounds that makes them more or less potent? Just as we discussed with the injectable anesthetics, potency of the inhalant anesthetics is a function of the lipid solubility of the drug. Here, there's a positive correlation between the anesthetic potency, expressed here as the MAC value on the y-axis, and the lipid solubility of these gases, expressed here as the oil-gas partition coefficient on the x-axis. Remember that the lower the MAC value, the more potent the drug. Also, the higher the oil-gas partition coefficient, the more lipid soluble. So, the more lipid soluble, the more potent. So what happens to the gas that actually goes into aqueous solutions? We know that a small fraction of these anesthetics does dissolve in the blood and other tissues. We also know that this dissolved portion of the gas is not responsible for the anesthetic effect. But does it have any consequences? It turns out that anesthetics need to dissolve first in blood and saturate it before it can form bubbles reflecting the partial pressure in the blood. If the gas is very soluble, this might take a while. But if the gas is not very soluble in blood, the gas can begin to accumulate in the form of bubbles almost immediately. So the solubility in blood determines the rate of anesthetic induction. Since the induction and recovery are just mirror images of the same process, recovery is also faster when the anesthetic is less blood soluble. On the other hand, the more soluble an anesthetic is in the blood, the longer it takes to reach a given partial pressure in the blood, and the longer it takes to produce anesthesia. Because recovery is a mirror image of induction, this means that it also takes longer to recover from the anesthetic. So to put it all together, a portion of the gas is dissolved in the blood and fluids, existing as a true solution that can be expressed in molarity. The rest of the gas remains in the gaseous form, existing as invisible bubbles in the blood and tissue. The quantity that exists in this form is expressed by the Mach values in terms of volume percent. The partial pressure is an expression of the oil-gas partition coefficient reflecting the solubility in oil, and this value predicts the potency of the anesthetic. On the other hand, the solubility of the gas in fluids is expressed as the blood gas partition coefficient, reflecting its tendency to dissolve chemically in water. And this value predicts the time required for induction and recovery from the anesthetic episode. Knowing this, now we can compare these properties using specific anesthetic compounds. Each anesthetic agent has a specific blood gas solubility that predicts its relative effect on the rate of induction and rate of recovery. They also have a specific oil gas solubility that predicts its effect on the relative potency of the compound. Notice that the newest compound, desflurane, has the lowest blood gas coefficient, while methoxyflurane has the highest. This means that desflurane has the fastest rate of onset, while methoxyflurane has the slowest. In the right-hand column, the oil gas partition coefficient is lowest for nitrous oxide and highest for methoxyflurane. This means that nitrous oxide is the least potent and methoxyflurane is the most potent. So in spite of the fact that the newer anesthetic compounds are much less potent than either halothane or methoxyflurane, they have much faster onsets of action, giving them this strategic advantage. The rate of onset of an anesthetic effect is very important because otherwise the animal becomes anxious and difficult to handle during a protracted induction. And because the recovery mirrors the induction, their recovery would be rough as well. So we need to use drugs that produce unconsciousness as rapidly as possible. There is one trick that you can use to increase the onset of anesthesia. This has to do with the phenomenon called the second gas effect. In this situation, two gases are mixed together, one having a low blood solubility, so it gets in fast, and the other having a high oil solubility, so it's potent. The gas that enters rapidly increases the rate of onset of the slower but more potent compound. The reason this works is because the faster drug, like nitrous oxide, is taken up rapidly by alveoli, creating a vacuum in the lungs. This vacuum pulls in more gases with it, including the other anesthetic. The clinical consequence of this is that the faster gas decreases the time for induction and recovery of the slower, more potent gas. It reduces the dose of the slower gas, and by doing this, it decreases the incidence of their adverse side effects as well. So basically, nitrous oxide serves as a superb delivery agent. Now, where do the anesthetics go? The tissue whose anesthetic concentration increases the fastest are those with the highest blood flow, like the brain, spleen, liver, gastrointestinal area, and kidneys. These areas increase in their anesthetic levels within seconds to minutes. The next tissues are those with the greatest mass in the body, which is usually the skeletal muscle system, where it can stay for hours. And finally, the last area that increases in concentration are areas with the lowest blood flow, but the highest lipid content, like adipose tissue. So the sequence of distribution of inhalant anesthetics is the same as the injectable anesthetics. The consequences of having a high concentration in adipose tissue are also the same. The drug can dissipate from this depot slowly over the course of days. Depending on the amount of drug in this area, this can cause effects on the animal that last for days as well. The majority of the gas is eliminated via the lungs, but some may diffuse from the skin or be eliminated with the urine and milk, depending on the solubility of the compound. Inhalant anesthetics exit in the reverse order that they accumulate in the body. They follow their concentration gradient, exiting the brain to the blood, and then leaving the blood for the alveoli. When the concentration in the brain falls below a certain level, the animal wakes up. Metabolism does not generally contribute to the termination of most inhalant anesthetics action. The reason is because only the portion of the anesthetic that becomes dissolved in blood and tissue can be metabolized. And that portion of the total gas in the body is extremely small for most currently used anesthetics. When it does occur, metabolism is primarily in the liver. Inhalant anesthetics are highly hydrogenated molecules. This means that the halogen ions are generated by their degradation. This includes reactive halide ions such as bromide, chloride, and fluoride. These metabolites can cause acute and chronic tissue damage, especially in areas like the kidney, the liver, and reproductive organs. So, in spite of the fact that metabolism does not contribute to the termination of the anesthetic action of inhalants, it does contribute to the potential toxicity of these drugs. This shows specific drugs in the order of their tendency to be metabolized in the body. You can see that methoxyflurane and halothane are the highest, whereas the newer compounds and nitrous oxide are the lowest in their tendency to be metabolized. As a consequence of this high rate of metabolism of methoxyflurane and halothane, they're relatively toxic compounds, explaining why they're no longer used in first world countries. In contrast, newer compounds like isoflurane undergo much less metabolism, and as a consequence, they're much less toxic. The inhalant anesthetics produce anesthesia by the same action as most of the injectable compounds. That is, they enhance the activity of the GABAergic chloride channel, allosterically increasing the flow of chloride through that channel in response to GABA. The exact site that volatile anesthetics bind is slightly different than any of the other binding sites on the complex, but the potentiative effect on GABAergic activity is similar. In addition to increasing GABA activity, they also increase glycine ion channels. They inhibit nicotinic cholinergic receptor channel activity, and they also affect the coupling of G proteins to their receptors. But unlike the local anesthetics, they have no effect on neuronal sodium channels. Taken together, there's a generalized and progressive depression of the CNS in response to these compounds. This is responsible for the depth of anesthesia. There's also an increase in cerebral blood flow, an effect that's greatest with halothane. This causes an increase in the intracranial pressure that may be dangerous for patients with any kind of head trauma or hemorrhage. As a group, they also cause skeletal muscle relaxation. This is central rather than a peripheral effect, so it's different than the effect of curare at the neuromuscular junction. Because their mechanisms of action differ in this regard, when the two types of drug are used together, they potentiate each other's effect and produce a profound muscle relaxation. Inhalant anesthetics tend to depress respiration, reducing alveolar ventilation so much that they may even cause respiratory acidosis. Horses appear to be more sensitive to this than dogs. Now, how does this happen? The respiratory stimulant response to increasing concentrations of PCO2, that is the chemogenic response, is blunted. Respiration is also decreased by opioid compounds and by other depressant compounds. So the combination of these drugs is usually additive. Because these compounds are often given with other drugs, it's something to monitor clinically. Inhalant anesthetics generally decrease blood pressure by relaxing the myocardium and decreasing cardiac output. This effect on the myocardium happens because they interfere with the calcium-mediated excitation-contraction coupling. Isoflurane is somewhat unique in that it also decreases the total peripheral resistance by relaxing vascular smooth muscle. This contributes to the decrease in blood pressure as well. There's also inhibition of sympathetic nervous activity because of the inhibition of nicotinic sites in the sympathetic ganglia. Remember that sympathetic nerves projecting to the vasculature are normally tonically active. This is to maintain a certain high level of vascular tone and keep the blood pressure up enough so we don't pass out. Inhibition of nicotinic receptors will attenuate this normal tone. The blood flow to specific organs is differentially affected by all these, such that the brain receives more blood flow, increasing intracranial pressure, while the kidney and the liver receive less. One consequence of the diminished blood flow to the kidney is that there may be a decreased urine production. Another thing to remember when considering the kidney is that the metabolism of methoxyflurane results in massive amounts of fluoride ions being generated, and these are particularly toxic to the kidney. So the routine use of methoxyflurane for veterinary anesthesia has been abandoned because of this nephrotoxicity. Now we'll cover the specific compounds that are used or have been used in veterinary medicine. Methoxyflurane was used for many years in veterinary medicine because it's potent but has a low vapor pressure, making it relatively safe. In other words, you could basically turn on the machine and it would only deliver a small amount, yet that small amount was usually sufficient to induce a safe anesthetic episode without displacing oxygen. Unfortunately, because of its high blood solubility, it has a slow onset of induction and emergence from the anesthetic episode. So it was usually co-administered with nitrous oxide for the second gas effect. The major problem with methoxyflurane was that it was so blood soluble that it was metabolized more than any other anesthetic compound, about 50% of it. And the metabolites cause renal toxicity. If the animal was previously treated for epilepsy, the situation was even worse because the metabolic enzymes would be induced by compounds like phenobarbital, and metabolism increased even more. Currently, it's only available as an inhaler for the temporary relief of pain, especially in children, where the renal toxicity is not so pronounced. Whether this could be used for a similar purpose in young animals is an interesting possibility. This slide summarizes the characteristics of halothane or fluothane and the reasons for its disuse. It's the cheapest volatile anesthetic, so it still could be used in some third world countries, but it breaks down over time, and in response to exposure to soda lime, the absorbent in anesthetic machines, so it requires a preservative. About 1/4 of the halothane that's delivered is metabolized, and the generation of bromide ions during this process makes it hepatotoxic. So in spite of the fact that it's cheap and it's potent, it's too toxic to use. In addition to liver damage, halothane also produces increased cerebral blood flow, sensitization of the myocardium to catecholamines, leading to arrhythmias, and also malignant hyperthermia in animals with a genetic predisposition to this problem. However, one thing that halothane has been used for and is useful for is the ability to dilate bronchiolar passages, for example, during asthmatic attacks. This is something that not all inhalant anesthetics do. Isoflurane is one of the go-to inhalant anesthetics used for many procedures today. Isoflurane, sevoflurane, and desflurane are all fluorinated ethers. They're all relatively stable in that they don't need a preservative. Isoflurane is approved for use in dogs and horses. It's not significantly metabolized, so the plasma levels of fluoride ions are minimal, resulting in no toxicity. In fact, it's the inhalant anesthetic of choice for birds and for critically ill patients. It produces a dose-related cardiovascular and respiratory depression, but it's less arrhythmogenic than other compounds like halothane, so the myocardium is not as sensitized to catecholamines. Isoflurane does have a major disadvantage shared by many inhalant anesthetics. It can also cause malignant hyperthermia in susceptible animals. Its advantages include some handy anticonvulsant activity. In addition to a relatively low toxicity, there may be the possibility of bronchodilation, so it can be useful during asthmatic attacks to open the airways, similar to what we talked about with halothane. It also produces excellent skeletal muscle relaxation. Sevoflurane is much like isoflurane. It's a bit less stable with the potential of forming olefin, a renal toxin, in the presence of soda lime. It has the potential of being metabolized, but it has such a low blood solubility that it doesn't get into the tissue where metabolism occurs. This low blood solubility also makes it have a rapid onset of action. It's also one of the least potent of all the volatile anesthetics, save for desflurane. In the brain, sevoflurane increases cerebral blood flow and intracranial pressure. In skeletal muscle, it produces good relaxation and also potentiates the actions of non-depolarizing neuromuscular blockers. It has only mild cardiopulmonary effects like isoflurane and little or no arrhythmogenic activity. But also, like isoflurane, there is the possibility of malignant hyperthermia in susceptible animals. Desflurane is so new that it's difficult to evaluate. It's terribly expensive. It's very sensitive to temperature, so it can be difficult to use in normal vaporizers. It's not potent and not metabolized. One big disadvantage of sevoflurane is that of the three, it does produce more greenhouse gases than any of the other inhalant anesthetics. Nitrous oxide is the only inhalant that comes as a gas. It's non-flammable and chemically inert. It can be delivered over a wide range of concentrations to produce analgesia or sedation with very low toxicity, but no anesthesia. It's useful for its second gas effects, and it causes low cardiopulmonary depressant effects or arrhythmogenic tendencies, but it can increase intracranial pressure. One important thing to note about nitrous oxide is that it should be tapered off slowly. Usually, you withdraw nitrous oxide prior to decreasing the oxygen, which can be given for an additional 5 to 10 minutes. This is because the nitrous is so blood insoluble that it not only enters the body quickly, it also exits the body quickly. As a result, it tends to diffuse rapidly into the lungs, filling them up and not allowing enough oxygen to enter. This is called diffusion hypoxia. Another related property of nitrous oxide is that it tends to diffuse into closed body cavities and causes events called pneumothorax, bowel obstruction, and air, or in this case, nitrous oxide embolisms. The human equivalent to this would be the bends that divers get when they surface too quickly. The rapid decrease in pressure allows bubbles to form and collect in joints and so forth. So to summarize, the anesthetic solubility predicts many of the important characteristics of these drugs. You can think of the body as being made up of two types of liquid, an oil phase and an aqueous phase, just like a salad dressing. Drugs need to be sufficiently lipophilic that they can pass through cell membranes. They're also soluble in water if they circulate in the blood as a solution. The oil-gas partition coefficient reflects the anesthetic potency such that higher solubilities predict higher potencies. In contrast, the blood-gas partition coefficient reflects the rate of induction and recovery such that high solubility predicts a slow onset of action. The most commonly used inhalant anesthetics are the halogenated ethers that include isoflurane, sevoflurane, and possibly in the future more desflurane. They're used because they have a lower toxicity than the more potent compounds that are basically of historical interest. Nitrous oxide is useful in conjunction with other gases or drugs, but not usually used by itself, except when it's used for analgesic or sedative purposes. This slide summarizes the advantages and disadvantages of the inhalant anesthetics. Test yourself with this type of a table. By comparing and contrasting the compounds, it reinforces their unique qualities. Be sure to focus on the ones you'll use in the future and add more detail to the chart when you take anesthesiology. This will help you integrate this information with the new material. The next subject that we'll cover focuses on the opioids, also known as opiates or narcotic analgesics. We'll see you then.